So welcome everyone to this Ethics Around the Table via Zoom, our first ever Ethics Around the Table via Zoom, it must be said, with Jim Thomas. I'm Sarah Stroud, I'm the director of the Parr Center for Ethics. And just to give a really brief heads up about our unit, if we have guests that aren't real familiar with us, we are the public face of Carolina's commitment to informed discussion of, inquiry into, and teaching of ethics on campus. Our mission is to nourish and foster ethical reflection on campus and beyond. We carry out that mission in part through a very vigorous speaker series. We have about 15 talks a year that we put on, both our lunchtime series, Ethics Around the Table, which we're about to enjoy today, minus catered lunch. That's a typical feature of Ethics Around the Table, which you'll have to supply yourself today. And our evening lecture series, usually under the banner Parr Center Presents, although we have a number of other brands for our evening lectures, which bring in nationally and internationally renowned speakers to give a talk and discuss with our community. So we're really fortunate to have with us today Jim Thomas, a world-renowned expert on global public health ethics, and in particular on infectious diseases, to speak to us about ethical pandemic control. Jim is Associate Professor of Epidemiology in the Gillings School of Public Health at UNC. His particular interests are in the social epidemiology of infectious diseases. He literally wrote the book on epidemiologic methods for the study of infectious diseases. That's a textbook available with Oxford University Press. And he's also been a pioneer in public health ethics. He led the creation of the first code of ethics for public health, which was adopted by the American Public Health Association and other organizations. He has served as an ethics advisor to the director of the Centers for Disease Control and Prevention. He has been working in the ethics of public health and in related areas of infectious disease for more than 35 years in more than 25 countries. So we're really happy to have you, Jim. Before I hand the floor over to Jim, I'm just going to put in a plug for our website and our mailing list. Please go to parrcenter.unc.edu to find out everything that the Parr Center is up to, and click the button at the bottom to sign up for our mailing list, and you'll get notified then of all our events, which presumably will resume being in person in the fall. Just a few technical notes. We're going to leave the participants muted during the whole presentation by Jim Thomas. The presentation will be followed by a Q&A moderated by the Parr Center Associate Director, Rob Willison. And in that session, you'll be able to raise your hand. You can do that through the participants menu, which is down at the bottom of your screen. You'll be able to raise your hand and get called on to give your question at that time. But until then, we're going to leave you muted. When Jim begins sharing his slide deck, I want to let everyone know that there's a view option that will pop up at the top of your screen. You'll see a little tab for view options. And if you pull that down, one of the options for how you view is side by side. That will mean that you'll see both what Jim is sharing from his slide deck, and you'll actually see a window of Jim himself speaking. So that might be an agreeable way to watch the presentation. We will get going now with Jim's presentation. Hang on a moment. We should be able to make sure you're watching Jim. Please go ahead, Jim. Let's applaud our speaker and hand things over to Jim for ethical pandemic control.
Deafening applause. Yeah.
Yeah,
Thank you all.
yeah.
Thank you all. Thank you.
There is deafening applause if you page through the
yeah.
if you page through the attendance.
Man.
Thank you, everyone.
I now see a screen. Well, I'm going to share my screen, and maybe we won't see that screen. Hoping that you all see me now.
Yeah, so everyone, if you go to view options at the top, that's where you can do side-by-side mode, and you'll see both.
So I'm going to be talking about ethical pandemic control, and I think I learned I need to click on my screen. Now that can go down. And first, just a quick statement about the difference between medical ethics and pandemic or public health ethics. In medicine, the ethics in that field is driven largely by the power differences between the patient and the provider. And in public health, it's driven largely by the power differences between the state and the state's residents. And because of these differences between medicine and public health, we see that autonomy rises to the top in one of the values in medicine, the autonomy of the patient and the ability of the patient to say no to what the provider is asking. In public health, sometimes that autonomy needs to be restrained because one person's infection is another person's exposure. And we sometimes need to constrain people so that they don't bring an infection to the community. So in public health, we stress interdependence, the fact that one person's health is affecting another's. So there's just the slightest mention of a difference between medicine and public health as we head into this talk, which is going to be with a public health lens. Now, already Sarah mentioned the Public Health Code of Ethics. She mentioned that I was involved in the writing of the first one, and that one occurred right after the 9/11 incident and became immediately relevant in that context. COVID is now occurring right after the writing of the revision of the Public Health Code of Ethics, which was released in 2019, late 2019. And so you're going to see me referring to this Code of Ethics throughout this presentation, and a number of the bits of that code are going to seem almost as if they were written after all of this occurred, because they are so spot on with the things that we've been seeing in this epidemic. But indeed, the code was written before, and it just shows the relevance of the code. There are some other documents that I'm going to be referring to down the road, and I'll mention that in the in the mid-2000s, there was a big effort afoot to prepare for a pandemic of influenza. And I was part of that, and during that time, a lot of thought was given to how states and hospitals should respond to a pandemic of influenza. That pandemic did not occur. There was an H1N1 epidemic, but it was underwhelming in terms of its effect on populations. And so there was not much done to follow up on that. However, we do have these documents, and I'll be referring to them down the road in this presentation. So I'm breaking up the talk here in 4 stages, what I consider to be 4 stages of epidemic or pandemic response. By the way, epidemic is a term that we would use in any country or city, and a pandemic is when that same epidemic cuts across borders, multiple borders, and in this case, it's around the world, and so that's then what we call a pandemic. But every now and then I'll slip into epidemic language. So in the 4 stages that I would mention are preparation, then the community phase, then the hospital phase, and the 4th is aftermath. So in the preparation stage, the Public Health Code of Ethics says that we are to detect, recognize, and acknowledge public health threats promptly and efficiently. I've got a clip from the Washington Post here, and you will see throughout that oftentimes I'm referring to the news. This epidemic is moving so fast that peer-reviewed literature, by and large, is out of the question unless something in the literature was prescient and relevant to what we're experiencing now. But in this Washington Post article, it's talking about U.S. intelligence reports from January and February warning about a likely pandemic. There was initial information that was downplayed, and the epidemic was considered to be the concern of other countries, not of the U.S., and therefore the U.S. was slow to act and not prompt. The importance of that can be seen in this slide here, where we're looking at two cities. The blue line that rises sharply is the number of cases. Is it cases or deaths? Looks like it's cases in New York City. And then if you look down lower, the gold one is San Francisco. On March 16th, San Francisco put in place shelter in place, which, if not all of us, many of us are experiencing right now. 6 days later, New York did the same. And you can see that in those 6 days, the epidemic took off, and the shelter in place would then have much less of an effect on that city. So prompt action in this pandemic is of critical importance. Public health has a problem of zero. It's my term to describe what happens when cases are low. So going back, you can see that, oh, look at March 12th, the cases were very low. And one of the concerns in public health when cases are low is that there's no perceived problem, so there's no reason to act. The curve here is number of cases, and once the curve peaks and then goes on the downslide, it gets back to zero, one hopes, and then at that point, you run into another problem of zero where people say, well, that's over with. Now let's put our money and our efforts elsewhere. And so things don't get followed up on. And this is something that public health has known throughout its history, and it remains a challenge for us. Another thing to do during the preparation is to provide adequate institutional and professional support to enable competent performance. This is a slide that is showing the number of positions in the federal government that are not filled. These are by agency. Obviously, some better filled than others. But because we have so many positions that are unfilled right now, there are wheels that won't turn, things that don't get done, or they get done slowly. What this table does not show also is a lot of turnover in positions. And with a lot of turnover, you get a loss of institutional memory, also very helpful and important when one is trying to act quickly. A third thing, and the last thing that I'm going to mention under preparation, is ethics preparedness. And the Code of Ethics says that we are to establish formal structures such as ethics committees to address and resolve ethical disagreements and challenges, and to enhance organizational ethics and decision-making. Following the first pandemic that we were anticipating, pandemic flu, there were, all states wrote pandemic flu plans, and some of them had ethics language in them. In a study that I did of the 50 plans, found that a minority of them had ethics language, and oftentimes the language was, we need to attend to ethics, and that was about it. And some of them, it was that we need to attend to the allocation of scarce resources in the hospital setting, which is the go-to ethical concern 90% of the time. It's the concern that is the most dramatic and the most eye-catching. Unfortunately, however, it's also the place where many people stop in their thinking about ethics in a pandemic. I did a follow-up study and a clip of it is presented here. Wake me up when there's a crisis. I went back to the states that said that they were going to improve their ethics guidance for a pandemic, and to check whether they had indeed improved. There were one or two that had, but most had not. And those that had stood out in that they had leaders in their health departments that were passionate about ethics and made that progress happen. Some of you, perhaps many of you, have seen the video called Poor Jennifer on YouTube, where this poor woman was involved in a Zoom call, and then she went to the bathroom forgetting to turn off her video. And I have, out of discretion, blocked off what others could see on the left side over there. But if you look over to the right, you see a number of people with their hands over their mouths, just aghast at this poor woman broadcasting this. It's now been seen by 3.5 million people. But the point that I want to make is that because of this preparation phase and our country's slow action and some cities' slow action, we got caught with our pants down and unable to deal with the epidemic in other ways down the road. There are some ethical issues we're going to turn to now that would have been less had we acted quicker during the preparation phase. So now we're into the community. One of the most important things in talking to the community is, as said here in a document coming out of the World Health Organization, the principles of outbreak communication are trust, transparency, communicating to the public early, dialogue with the public, and planning. This is a common sight for many of us to see the White House briefing on COVID. And the point I'm making with this is that those of you who have seen this and those of you who have followed the news, notice that we have a number of faces that sometimes are giving different messages. There's not a singular voice coming out of the White House, not a singular voice coming out of leadership in how we are to respond. There have been instances where President Trump will say one thing, and then the man just behind him with his arms crossed, Tony Fauci, will step up and say things differently. And that dynamic plays out in a number of different ways that cause us to be a little confused about how to proceed. That occurs with the backdrop of hyper-partisanship in our country, and not unique to the Trump administration, but over the last couple of decades, we have seen a deterioration of trust in institutions in general. And so it's not only have we not had a consistent message, but even those messages get doubted because of the lack of confidence in institutions. The Centers for Disease Control and Prevention has said that we are to employ the least restrictive interventions that are likely to be effective. Now, this gets to that point in public health that I made early on about how sometimes we need to restrict liberties or autonomy in the interest of the good of the community. So the general rule, not just stated by the CDC, but by others, is that if you're going to restrict civil liberties, do it in the least restrictive way possible. One of the challenges in this epidemic is figuring out, well, what is effective? So this often seen diagram here shows what happens without protective measures, and principally we're talking about social distancing and staying at home. You get a rush on the hospitals like we're seeing in New York City right now, and the beds are overwhelmed. There's a lack of many different resources within the hospital, and because of that, you get more deaths. And then the blue curve is showing what ideally happens with protective measures, that it decreases or at least slows down the number of cases so that the healthcare system is not overwhelmed. But the question is, how much is enough? How much social distancing is enough? We've all experienced how it incrementally gets tightened down. But I was involved in media interviews early on in the epidemic where I would say that, well, in this case, it seems to be more than needed, and in this other case, it seems to be more appropriate. But as the days go along, I find that the things that, the restrictions that I once called overdone or possibly unethical have begun to look more ethical. And that makes it a moving target. Recognize and act upon the fact that the ethical obligation to provide access to health care is not limited to persons with citizen status only. Here an example is farm workers. We've got a lot of those in North Carolina, and in their dwellings, they are in dormitory-like settings. And if one of them gets sick, how are you going to isolate them? Where can they possibly go? They're not going to go back to Mexico. We don't have a place for them. There's been some advocacy to get some hotels and use them for infected farm workers, but that remains to be seen whether that's going to happen. And prisoners alike are even less able to escape an infection. This story here shows how some of them are being released, in some cases released with ankle bracelets so that they can be monitored, but one has to take care for the possibility of a wildfire running through a prison. Stage 3, now we're in the hospital. And the Centers for Disease Control says that first come, first served should not be a criterion for allocation. They're speaking here principally of things like respirators or ventilators, as they are also called. Here's a photo of one from an ad. This one is all too calm for the current setting, but one of the curious things about first come, first serve is that in the early part of the epidemic, when people are trickling in, you're not going to withhold a ventilator and wait for another person to come in and see if they are more needy. But if you're in a state where you are overwhelmed and you've got several people and more than the ventilators that you have, once a ventilator becomes available, the CDC is saying, or was it WHO, I forget which, was saying that you should not make first come, first serve the criterion. One of the reasons being that the people who are able to come first are often those who are wealthier, who have more access to transportation, and that may bias their ability to get those resources. Other considerations might be things like age. That's one of the criteria that is often considered in allocation of scarce resources. In my work with public health ethics, I have also done some cross-cultural comparisons, and interestingly, in some cultures, age is given preference. Older age is given preference, whereas in the US, we're more likely to give preference to younger age. Should I become sick, I'm of an age where I think I would prefer to be in one of those countries where they revere their elderly. And then we don't want to exacerbate inequities. Public Health Code of Ethics says that we should ensure that public health policies and plans are sensitive to race, ethnicity, sex, sexual orientation, gender identity, and other unique characteristics of individuals affected by the policies or plans. This is a chart that was just in today's New York Times showing that, so you see from left to right, we have a calendar running from February 16th to March 29th, and the lines are showing the, what should we call it, the proportion of people or the rate of people moving around as judged by cell phone GPS data. I'm sure it's been aggregated, it's not individualized, but still you're able to see that early on, that was normal. And then looking around March 8th, the decline is the social distancing and people staying put in their houses. And the brown lines are low-income people, the bottom 10% of income, and the blue is the top 10% of income. This is showing in a graphical way that, as the article says, that staying at home is a luxury for those who have a good income. The others are going to the warehouses to pull the things off the shelves that the wealthy are ordering on the internet at home. So how do we go about instituting something like social distancing without exacerbating our inequities? There are obligations to the caregivers, and the World Health Organization says that we are to provide preventive measures, they're listed here, to help coworkers in line with technical advice and updated as new epidemiologic evidence becomes available. Well, that's a problem because we have a lack, because of that earlier stage of preparation, we have a lack of those protective, that personal protective equipment, the PPEs. This article is coming from an organization called Doctors Association in the UK. So this is a British organization, and they're on their website, they're bragging about how they were cited in the newspaper The Guardian, and it's an article about doctors improvising masks out of snorkels due to severe PPE shortage. And I looked this up. Notably, this was published on April 1st, and I was a little wary about whether this is a joke. But in looking into it further, it indeed is not a joke. And there are many examples of how people have been improvising to have the protective gear to work in a hospital that does not have enough. New York City or New York State has said that they are going to run out of adequate numbers of protective gear in a week. And they probably haven't peaked yet in the number of cases coming into their hospitals. And now we're going to go into the aftermath of the pandemic. Here we are to incorporate lessons learned from experiences into future design and implementation efforts. The kinds of things that we might want to ask, or let me mention first, that we want to get some stakeholder input from, well, we could go back and we could talk to the farm workers or representatives of the farm workers. We could talk to folks from the health department. We would want to talk to small business owners, and the list goes on of stakeholders in how the epidemic control was handled. What went wrong? What went right? And then in doing that, we might compare various cities and settings. Again, in today's New York Times, we have another article that shows how the number of cases, these are deaths actually, are rising, how fast they're rising in different cities. They start from when the city had its first 100 cases. So then the bottom left, there's the 100. And then going from left to right, it's the number of days since that 100th death. If you go to this table online, it's interactive and you can drag your cursor over it and other cities will appear. Seattle lines up with that bottom line, and which is not on this table here. But then if you look at Chicago, you can see they are earlier into the epidemic, but their curve is not rising as fast as New York City's curve. Well, we might look across different cities to see how their experience, why their experience differed, and gain some insights into what we do when we next encounter a respiratory transmitted pandemic. We are with this information to encourage policy development to protect the public's health. Now, there are some things that have been occurring in this pandemic or this epidemic that are new to public health. One of them is cell phone tracking. Now, you saw a diagram a little while back about how we use cell phone data to the GPS data to see how much people are staying at home, how much they are social distancing. And that's an amazing tool. If any of you have seen the television series Black Mirror, that series is about taking a technological advance such as this, and then taking it one step further into a dystopian perspective. And as we look at each of these technologies, I'm going to show you a couple more, we need to mentally be doing that in our own heads of how could this go wrong? How could the answer to one problem become the creation of other problems? And this article here raises the question of whether there are some privacy concerns with the use of the cell phone data in an epidemic. And in China, they have used drones to monitor people. So you see the drones over there on the left, and then on the right, you are looking through the drone's camera at people below. In the upper right of the right photo, you see in regular colors what the drone is looking at. And then in the purple, you see it zoomed in on those people and assessing their temperatures. It's a heat monitor, and they're able to identify people who have a high temperature. And I don't know what follows should they identify somebody, but this is another example of a new technology used in an epidemic, and something we need to keep our eye on and to consider as Black Mirror would. How could this go astray, and what do we need to be watching for? Those are the 4 stages of the pandemic. I'm going to close by talking about something we are doing here at UNC. We are creating a pandemic ethics dashboard that allows us to identify quickly the ethical issues and the best available guidance on what to do with them. This is not the dashboard that I'm going to tell you about. This is another dashboard that perhaps all of us have seen that comes out of Johns Hopkins, but it's showing the occurrence of COVID-19 cases around the world. And what we want to develop here, what we are developing here, is a dashboard that is based on the guidance that I have shown you, these 4 standard pandemic ethics documents that represent a consensus on best practices, and then the Public Health Code of Ethics. Our dashboard, which is in development, and I thought twice about showing this to you because it is so ugly. It is very early in development. You're seeing something very raw here, but it allows me to show you the setup and what we're aiming to do. So if you look across the, I think my cursor is going to show up for you. If you look across this banner here, you can see the 4 stages of the epidemic or the pandemic that I mentioned to you. Then we've got a list of resources over here, and there's the About page. I'll come back to that in a second. Over on this column here, you have common ethical questions. And in the middle here, you have the excerpts from those documents on pandemic ethics. You can see that I've got here some from the WHO, and then down below further from the CDC, and it goes further on to some of the other ethics documents. And then on the right, you've got the Public Health Code of Ethics and excerpts from there that are relevant to a particular ethical problem. In this case, and don't read too carefully because you're going to find this doesn't line up, but over here we've got establishing ethical decision-making processes. So this whole page would represent everything in these documents that relates to this question of decision-making processes, and everything in the Code of Ethics that relates to the same. And when you click on one of these, where it's going to take you is to the source document, in this case, the Code of Ethics, so that you can see the full text of what it is saying and the context of where it is in the document. And public health, this is designed for public health professionals at the city, county, state, and national levels. Public health professionals, I have been one. I worked in the city of Los Angeles as an epidemiologist. I know that those people, very hardworking, can be overwhelmed, as we all would, by an epidemic, have very little time to reflect and to go and research things. And yet these documents are available, but not very accessible to anybody who is not initiated into where they are. So this dashboard is going to enable people to quickly go to the most common ethical questions and quickly see what the best practices are so that they can judge whether their actions are in line with that or if they need to make some changes. Going back to the About page, there I'm going to be talking about the departments and the centers within UNC that are contributing to this page, that are supporting this page, one of them being the Parr Center. And of course, also the Gillings School of Global Public Health, which is my institutional home.
Thanks, Jim.
And we are done. So I'm ready for any questions.
Great, thank you. Thank you so much, Jim Thomas. Thank you so much. Can we get a round of reaction applause for Jim, please? And you feel free to also clap on your video if you're using video. Great.
Or you can just send money.
Thank you so much for outlining all the key ethical issues for us from, as I said, a world expert. We're very fortunate to have this kind of expertise at Carolina. We do have time now for questions and exchanges with Jim Thomas. So let me introduce my right hand, my Associate Director of the Parr Center, Professor Robert Willison, who's going to moderate the Q&A. Take it away, Rob.
Great. Hi, everyone. Let me just first say what procedure we're going to try to operate with here. If you go into your participants dialog, which you can access by just scrolling over your video, and there should be a little button on the bottom that says participants, a separate dialog should come up, and that should allow you to raise your hand. And so if you raise your hand, you'll pop up. I can see Walter Armstrong from Duke has already raised his hand, so he'll probably be our first question. I will then, I'll call on you and unmute your microphone, and you can ask your question for Dr. Thomas. Okay, so Walter, why don't we start with you?
Sure, thank you very much. That was a great talk. You covered an awful lot, and I just wanted to ask you to dig down a little deeper on one thing that you mentioned. You referred to this slogan, the least restrictive measures that are likely to be effective. But of course, likelihood comes in degrees, and so does effectiveness. And so I take it that the right way to understand that is that it's the least restrictive measures that are likely enough to be effective enough, and presumably also without harmful side effects. So I guess I want to ask you, how do we determine how much is enough? And in particular, do the financial costs of some of these measures bear on how, whether it's, likely enough to be effective enough without having, horrible side effects?
Yeah, and then without bankrupting a country, which is another aspect that we're wrestling with, isn't it? Those are great questions, and you can see that almost any of these ethics, we can't really call them solutions. We can call them guidance. Get complicated really fast. When I was working as an advisor to the director of CDC, we had a panel of people that were gathering together, a panel of ethicists, and folks in the CDC would bring to us questions from one of the institutes, and they would sit with us as this group of ethicists would begin to reason things through, and almost inevitably, they were frustrated because the first thing we would do was complicate the question with more questions. And it was only after, 30, 40 minutes of doing that we would begin to select the pieces that were the most available and relevant and begin to narrow in on some advice. But as you have demonstrated, when we're doing ethical reasoning, things get complicated before they get simpler. And for that reason, I think that just underscores one of the reasons it's important to have a committee that can wrestle with these things. They're unlikely to be PhD ethicists, but they should be people who have some tools available to be thinking about ethics. And hopefully this dashboard we're providing will help some, but as you point out, it's not going to go into the depth that it could. However, on the resources page, we are going to provide documents that go into deeper detail.
Thanks, Jim. Our next question is from our founding donor, Gary Parr. So Gary, I'm going to unmute you right now.
Okay. Hello all, and hi Jim. Thank you. It makes me very proud actually to hear a professor from Chapel Hill with such great expertise. I'm delighted to be a Carolina grad. My question is, how would you help the policymakers think about the most important ethical issues of the trade-off between the people being in isolation and the damage to the economy about when people can go back to work? How does one, I'm not asking for the answer, I'm asking for the framework. How should they think about that? How does one balance economics versus lives or secondary lives? How would you propose they think about it?
Boy, the challenges we face in that debate, that discussion, is the backdrop of the hyperpartisanship that I mentioned, and the speed of the epidemic. It's hard to get people to pull aside and to have a conversation. But I'm finding that people such as myself, we do have access to the halls of power, at least in the state here in North Carolina. I've been invited into a number of discussions and have been able to introduce some thoughts that begin to allow people to think these things through. I think one of the first things that I would mention is finding a language of respect with those who have differing perspectives. In talking to a person in our Congress who is thinking principally about the economics, I would want to acknowledge that yes, that is a concern. One of the important elements of public health ethics, one of the most important elements, is humility and the ability to say that I could be wrong, but this is what I believe and this is why I believe it. Then another place that I would go is to look at some of the technologies that we have that may be able to find a middle road. I think the middle road between these two different partisan perspectives is changing the conversation from an either or to a shared goal. And the shared goal would be, when can we lift up these restrictions? Let's talk about a clock now. We all want to do that. What are the criteria for when that can happen best that would allow people to leave their homes? And the technologies that I referred to earlier were tests for immunity. Those who have had an infection and shown to be immune would be able to rejoin the workplace sooner than others. There's kind of a shotgun answer to your question. I hope you found something.
And by the way, as Sarah knows, I was not introducing politics at all. I was asking an ethical question. How does one ethically approach the right answer? How does one get to truth? I was not asking a political question at all.
Well, unfortunately, it is very much shaded by politics right now, but
it shouldn't be. But that's truly not my question. I don't care about that. I'm asking, how would you guide people to truth in search of a right answer?
Yeah, and so my short answer would be to focus on that common goal of how do we set the criteria for when we should ease up these restrictions.
Okay, thanks. Thank you.
Mr. Chairman, Rob, can I ask a question?
Sure. I have a question too. So
okay.
Go ahead, Sarah.
This really sort of follows up on what Gary was asking, which chimes in really well with what I was wondering about, Jim. So I will, with the permission of Mr. Chairman, I'm gonna promote myself here. I was wondering if, in addition to thinking about which responses, technologies, and so on are ethical to put in place during a pandemic, whether there are also ethical constraints on how those policies, technologies, strategies, and so on get decided. In other words, there's a range of ways that these things could be issued, from just sort of a panel of experts decreeing, this is what we're now going to do, or this is what everybody has to do to comply, to more sort of democratic or participatory models of decision making over these kinds of measures, where I guess the worry would be that expertise maybe would get diluted by people with less expertise. But on the other hand, there would be a greater range of voices at the table. Do you think that the question of how to decide on appropriate public health measures during a pandemic is itself an ethical question that we need to think about from an ethical perspective?
Absolutely. I would hazard that all, if not most of those documents that I showed you mention the importance of stakeholder input, and that the stakeholder input should be diverse. I can tell you from my personal experience in the groups that I have participated in where there is diversity of experience, where they are not all experts, that there has been eloquent things that are said by people who are not experts, but bring a perspective that the rest of us miss. And invariably, that perspective is treated with respect and begins to influence the decision-making process. So I think absolutely, theoretically, yes, and in practice, I have seen that work well.
Thanks, Jim. And please let me hasten to say to all those attending, do not be deterred from raising your hand by the fact that the director of the center has jumped the queue. Please, let's resume the general discussion.
Sure. We have a question from Ravita. So Ravita, I'm going to unmute you now and you should go ahead and ask your question.
Okay. Hi. I'm trying to, oh, there's my camera.
Hello, Ravita.
Hi. I'm so thankful for this presentation today. I chair the chapter ethics committee for NASW North Carolina, and just everything you said was very, very helpful. As a therapist, I'm working with many clients who don't have masks, and I don't know if this question is appropriate, but I'm just wondering, where can lay people find guidance on if they're going to try to have some kind of covering at home? We understand it's nowhere near the medical grade quality, but is there any reliable information about the best way to do that?
So what you're bringing up here is a line of ethical questioning that is not yet on the dashboard and is intended for a future version, which is the ethical responsibilities of individuals in the context of a pandemic, obligations to them as well as obligations of them. But now back to your particular question. Where can we find guidance on masks? That is a hot topic right now. There is a lot of news coming out daily because CDC changed its thinking on suggesting that people wear masks. They are not the medical grade N95 masks. Of course, those are to be preserved for people who are in the hospitals. And then there is advice on how to make masks. And in my house, I don't have any of the masks that you're talking about. And were I to go outside and into public, I would be looking at how to make a mask. I'm sorry, I don't have a link or a website to point you to. All I can say is watch the major news channels or media. And there's likely to be some advice. I think even on the New York Times right now, there's some advice on how to make a mask. Buying one is going to be really hard. Sorry, I don't have a better answer for you.
Okay, I just didn't know if there was any material. I've seen a lot about different materials that help, so I didn't know if there was something that would be helpful to be included. But I appreciate everything you shared.
Probably so, but I don't know the answer.
Okay, thank you.
Mm-hmm.
Thank you, Ravita. We're going to go to Lindsay next. So Lindsay, I'm about to unmute you.
Hello, thank you so much for hosting this talk. Kind of going off of what Ravita said about the masks and thinking about the ethics involved in allocating resources, preparing the public, and protecting the medical care workers. How do we hold those responsible or accountable, or how do we hold people that are responsible for putting in place kind of these guidelines accountable for their actions? Are we looking mostly at like the stakeholders that are involved? Because a lot of the actions that I've seen in trying to, release the prisoners or trying to make sure that, resources aren't allocated to only young and healthy people, quote unquote, which I know is a big thing going on in Italy right now, where it's a lot of activists coming through and saying, how do we properly sorry, I'm kind of going all over the place, but how do we hold these people accountable for their actions? And
right. So well. So how do you hold the decision makers accountable, or the device providers accountable, or the people who are using those devices?
I think it's the people that are kind of putting. Wait, will you repeat that again for me, please?
Well, so let me take a shot at this, because it was decided that the national stockpile of protective equipment was to be built up over the years, and it was found that it was not. It did not happen, and which made us caught unprepared. So the code of ethics and other codes would say that that was an unethical thing that happened. But where are the teeth in making that kind of an ethical statement? A code of ethics is not law. It doesn't say that if something is not done ethically, that they are to be fined or to be imprisoned. In the medical code of ethics, which applies to clinicians, there are some steps that can be taken to take away a license, for example. In public health, we don't have that. So what we are able to do with the code is to say that's wrong, and that our profession does not agree with that, but we don't have the teeth to reach out and say, therefore, we are going to punish you in this way. I think probably the closest we can get to that is to make the ethics known, so that the population can recognize what the standards are, and perhaps hold people accountable through other means, including elections, but maybe some others as well.
Thank you.
Mm-hmm.
Great. Okay, next in our queue is Ray. So Ray, I'm going to unmute you. Why don't you go ahead?
Hello, Professor Wilson. My question pertains to the process again, and I was wondering about Presidents Kennedy and Obama were famous or infamous for pulling together truly diverse and large collections of contributors into their decision-making process. And I was wondering how that itself bears in this setting. Thank you.
Well, you're speaking at a higher level than what Sarah's question was about. Sarah, I think, was talking more about at the micro level, say a hospital level, how things are decided, or a state level. What you're referring to, yes?
I was pulling on Gary Parr's question more specifically.
Mm-hmm. Well, so what I would note, what I would note is that I think that there is strength in diversity, and particularly in diversity of experiences. And I think, it can't be overstated that we need to have people who have come up through blue-collar jobs, for example, who can speak to the difficulties that a pandemic presents. That kind of information is just invaluable in understanding how a nation is operating. Were I president, were I president, that's the kind of group that,
2024.
yeah, right. That's the kind of mix that I would be looking for. People who have been unemployed, even people who have been homeless, that can be articulate about those things, because there's a lot of wisdom to be had there.
Thank you.
Dr. Thomas, I'd love to ask you a question if that's okay. I'm curious, and I think this is sort of a follow-up on Sarah's question about what's the process of making a decision in a variety of these situations. And I wonder if just de facto, frequently when things are moving quickly, the people who end up making decisions are the ones who have the sort of power and access to the technology or to the data or the authority in the case of a hospital, and they end up just making those decisions. And I'm wondering, is there sort of, in the case where, for example, corporations have a lot of data that might be useful for the government or for public health agencies, or corporations have kind of manufacturing power that might be useful for producing necessary PPE. Do you have any thoughts about what the relationship between the government and the private sector should be in addressing a crisis like this?
I'm going to say two things. First one is that because a crisis is so frenzied, that accentuates the importance of the preparation stage, when decisions can be made not in a heated moment, when you can gather stakeholders from a wide variety of places and have thoughtful discussions. That's why I emphasize that stage as an important one for pandemics. The second point I'm going to make is that you have hit on something that before I was pulled back into pandemic ethics by the pandemic, I was dealing with digital data and surveillance ethics, and how new sources of data are becoming useful to public health, but they're not collected by the government as public health surveillance has been done for ages. It requires new relationships between the public and the private. The slide I showed you of the cell phone data and the monitoring of how much people have moved around is an example of that. Those data were not collected by the US government. They were collected by, I don't know, AT&T or Sprint or somebody like that to make that kind of a chart. And it raises questions of how those interactions are going to occur, what kind of data are going to be shared. Is the government going to be subject to the whims of the private companies that they will produce those things when they darn well please, or can the government lean upon them to produce those sorts of things? Those are places that we need to be going right now, and I'm going to try to start writing about them once I get this website done.
Good. All right. Well, we're looking forward to that. I think we have time for one more question. And just before that question gets asked, I just want to direct everyone. There's been a lot of useful information in the chat window that's supplementing a lot of the answers that Dr. Thomas has been giving. So for those of you who haven't been taking a look at the chat window, I think we'll also have a record of that, but I recommend that to you to take a look at it if you like. And now for our last question of the afternoon, I'm going to go to Robbie Bean. So Robbie, I'm about to unmute you. And you should be good to go. So go ahead and ask your question.
Okay, thank you, Dr. Thomas, for the wonderful presentation. I'm curious, as I reading the news about Johnson & Johnson potentially coming up with a vaccine for the virus that might be implemented next year. I'm curious about sort of the ethical systems that our country has in place in terms of medical testing, whether or not how that will impact our society during this time, and whether or not there's strict government oversight there, or whether that's happening at a private level as well.
There are so you're speaking to the standards of vaccine testing and the procedures that will be followed through that?
Yes, exactly.
Yeah, those standards are pretty well established and regulated, and a vaccine trial has a lot of steps that it goes through, and there's a lot of monitors to those trials. There has been talk about loosening standards to speed things up, and that makes me a little bit nervous as a researcher. I'd like to know more about what standards they're planning to loosen up and what effect it might have. If one of the most valuable assets that public health has is the public's trust, and if we create a vaccine that backfires in some way, it's only going to undermine the trust of the public, and the follow-up vaccine will then be doubted, and it'll be just a mess. So it's very much in our interest to proceed in a way that allows for the results to be an effective vaccine, and one that has been developed through with ethical guidance. And as I've said, there's a lot of steps, ethics review boards that will be watching over that research.
Thank you.
Folks, we should draw the formal session to a close as we're past our time. It's been such a pleasure to have all of you aboard for this wonderful, and I must say rather reassuring presentation. The thought that there are people thinking through all these issues as calmly and thoughtfully as you are, Jim, actually has made me feel a bit better in the face of these strange times. So we are